Hello, everyone. Good morning. This is Siddharth Damber from Chicago Arthritis and Regenerative Medicine. Before we get started, please let me know if you can hear me speaking and whether you can see the screen and the webinar. Okay, great. Thank you. And actually, just before we start, please let me know where people are viewing in from. Great. So again, my name is Siddharth Damber. Today we're talking about regenerative medicine for arthritis, tendinitis, injuries, and back pain. To give you a sense of what you can expect during this webinar today, you'll learn about the best available non-surgical treatments for arthritis, tendinitis, including stem cell blood platelet treatments, what is legitimate and not legit in the field of regenerative medicine, and how to really choose the best physicians and clinics for your regenerative medicine treatment. As we go along, please leave me your questions and I will pause here and there to answer them. This always works better when there's kind of give and take, and if I'm addressing what your questions, concerns, and interests are. So, big question is, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? And what activities with family and friends would you participate in? So who am I? Again, my name is Siddharth Damber, physician here at Chicago Arthritis and Regenerative Medicine. Specialize in rheumatology, also specialize in image-guided musculoskeletal injections. I've been in practice since 2008 here at Chicago Arthritis and been involved in regenerative medicine since 2008 and within the Regenix network since 2012. The Regenix network is the largest network of affiliated physicians that are involved in regenerative medicine in the world, where we share best practices, protocols, and collecting data as well to help shape the kind of treatments that we offer to patients. So my personal journey into regenerative medicine started with my own shoulder. I was a tennis player when I was in high school. I had stopped during young adulthood, but picked it up in my mid-30s. Had a little bit of pain in the shoulder at that time. I had a diagnostic musculoskeletal ultrasound done as I was learning that modality as well. Found that I had a very small injury to the tendon. And in my interest in ultrasound, I started to learn a lot more about tendon and ligament injuries, which led me to understand how inadequate the current model of care is for treating these conditions. So traditional care really is insufficient when it comes to treating for arthritis, joint pains, tendinitis, tendon tears, sprains and strains, and back and neck pains. Really, the model of care is very much mask the pain and then essentially waiting for eventual surgery. The equivalent of that for other conditions would be if you had early diabetes or early high blood pressure, and rather addressing that with lifestyle and perhaps medications, it would be to just wait until you had your first stroke or heart attack. That's essentially how we're treating things like arthritis and tendinitis and injuries and back pain. And it's really unacceptable with that when it comes to treating diabetes and high blood pressure and other medical issues. And really, it should be unacceptable when it comes to how we treat your musculoskeletal conditions. So problems with traditional care: pain medications, they don't fix the problem. If you're taking chronic anti-inflammatory medications, there's issues with potentially damaging your kidney, stomach, liver, heart, and bleeding risks. If you're taking chronic narcotic pain medications, there's obviously a lot of issues when it comes to addiction issues and all the stuff that comes with that. The traditional injection options are really not good either. Steroid injections have the potential, if you take them too often, to damage tissue, infection risk, diabetes, osteoporosis. a lot of the more common nerve block and radiofrequency ablation treatments, they can give pain relief, but they do damage a nerve, which can then lead to muscle weakness, which is really not good for your overall musculoskeletal health and your overall medical health either. Surgery has a appropriate place when it comes to your musculoskeletal health. In particular, if you have really severely torn tendons or really badly damaged joints, but it does have higher risk when it comes to bleeding, infection, tissue damage, anesthetic risks, and cardiac risks. And if you're using it to treat mild to moderate conditions, you're going to actually accelerate the arthritis progress by causing more instability. And as you'll see, as I talk a little bit further, many routine surgeries are not only proven to not be effective, let's say knee arthroscopy surgery for if you have arthritis, but eventually 80% of musculoskeletal conditions that are going to surgery will eventually be able to avoid surgery. There are quite a few conditions, even knee arthritis, when you start to talk about moderate to advanced knee arthritis, that can still benefit from a regenerative treatment without having to go to full-on knee replacement. So in searching for better options, we need to have treatments that are low risk, avoiding side effects that you can see with surgeries, that can actually treat the cause of the problem, which I'll talk about, and that can give you longer term improvement as well. So imagine being able to reduce your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is essentially the practice where you use your own body's cells to treat arthritis, tendinitis, injuries, and back pain. So if you think about what the normal healing process is, take something as simple as if you cut your finger, a small cut to your finger. What you have is an influx of platelets that come into that area. The platelets release a bunch of growth factors. Those growth factors stimulate your own local stem cells, which then starts an inflammation process and then a healing process, which then takes a couple of weeks to a couple of months, depending on the degree of injury. That works fantastic if you have good blood supply to an area. The problem is for areas that are poor blood supply, whether that is cartilage, joint lining, tendons, ligaments, discs, labrums, meniscus, they don't have good blood supply. And so if they've been chronically injured, or if they have had too severe of an injury, then eventually they start to lead to progressive damage and instability. So regenerative medicine is a process of taking those same cells, whether it's your own blood platelets or your own bone marrow stem cells, and then injecting that under high-level ultrasound and X-ray guidance into the tissue that's been damaged to actually help restart that normal healing process. So again, why regenerative medicine? Number one, I'll explain how we're actually treating the source of the problem. These are dramatically safer than surgery. These are needle-based injections. So to give a comparison to other parts of medicine, the way heart conditions, coronary artery disease used to be treated was predominantly with open heart surgery. Dramatically higher risk than if you were doing this via an angioplasty or angiogram, which is just using needles. And so the vast majority of cardiac disease now is treated via either medications or needle-based procedures, avoiding much higher risk open heart surgery and really only using that for the most extreme conditions. And so regenerative medicine, when it comes to orthopedics, will be effective for most musculoskeletal conditions. And for those of us that are already using this, we feel that 80% of traditional orthopedic surgery should be managed by regenerative medicine. So how does regenerative medicine work? You're really optimizing damaged cellular health of tissue. That's the primary way. Again, you're taking tissues that have been damaged and you're now re-injecting the cells, platelets and stem cells that are meant to start that normal healing process. So what we know is that when you take a look at a damaged joint or tendon, you have cells that are no longer pumping out the right kind of proteins and enzymes. That's what leads to chronic inflammation. That's what leads to pain. We know that the treatments that we utilize can get those cells to start putting out the correct proteins and enzymes that you see in a healthy joint. In addition, we know that when you look at stem cells in a damaged joint, that they're no longer functioning well, and that by re-injecting your own healthy stem cells into that area, you can get those original cells to start functioning appropriately normally again. In addition, and I'll talk about this a little bit further, that what drives most arthritic issues is chronic instability. You have damage in a ligament or tendon, a strain or a sprain at one point in life, and that then leads to instability. And that instability eventually puts more stress on the joint and the cartilage, which then leads to what you typically see in an arthritic joint, with joint space narrowing, bone spurs, and more pain. So the treatments that we offer can help to support those damaged soft tissue structures. And by doing that, you can actually lead to less pain and better function, because you're actually improving and strengthening what's actually causing the pain. In addition, when you have chronic inflammation in a joint, we know that these treatments, while they can cause inflammation up front, longer term, they'll actually reduce inflammation. And then lastly, one component of chronic arthritis and tendonitis pain is damaged nerves. That your nerves are essentially what senses pain. And we can actually treat those nerves by not only making them healthier, but also by reducing some of the stress that you see on them that you see in chronic pain as well. Again, as I'm going along, as you have questions, please jot them down and enter them into the chat section, and I'll be sure to answer them as we go through. So common questions that people have, really the basics. Number one, is this legal? Simple answer is yes. There are very strict guidelines that the FDA has, and here are those guidelines. Number one, you have to use your own living cells. If you're using your own living cells, you're inbound. If you're using somebody else's cells, you're potentially out of bounds. Number two, the cells cannot be significantly altered or adjusted. What that means is that the way that they are prepped needs to be done in a way where you're not dramatically changing the nature of the cells. And number three, you need to inject them into damaged orthopedic tissue. If you're interested in how do you treat things like chronic diabetes, heart problems, lung problems, number one, those are not within FDA guidance for practicing physicians to use at this time. And number two, that's way outside, obviously, my own expertise as well. I'm really strictly focused on utilizing this for arthritis, tendonitis, injuries, and back pain. So great question. Somebody asking, does the FDA allow stem cells to be proliferated or actually grown out? So again, not for clinical use in humans. So in the Regenerative network, that was the original way that they used to do these procedures. They used to do this with cultured stem cells in the United States. That is not allowed in this country. So Regenerative has a clinic in the Cayman Islands where that is allowed, but in the United States, the FDA does not allow stem cells to be grown out. And I think that's frustrating for patients as well as for, I think, physicians who are involved in the field. But the reality is that the FDA is trying to get just broad, general regulation and control of the field of regenerative medicine to make sure that things are being done appropriately and safely. And so I think it'll be quite some time before they actually allow your cells to actually be grown out and cultured in this country. Another common question that I hear is, if I'm older, shouldn't I use somebody else's cells? Again, you'll hear some physicians say that. And it's interesting because they kind of appeal to the idea that, well, if you're older, clearly your cells must not be in very good shape. That's not really true. What we know is that for most orthopedic conditions, there's strong evidence that using your own living cells is effective and appropriate. There's definitely additional risk when you're using somebody else's living cells. There's a condition called graft versus host disease where your body will actually reject somebody else's cells. And in fact, in this country, it's considered illegal to inject somebody else's living cells into your cell for treatment. The only exception being for childhood leukemias, and if you're doing even adult leukemias, if you're doing that for adult stem cell transplants. But essentially, using your own cells is the right way to go. Your body is fine-tuned for that, and that's what you should stick with. And then, is there an age limit? Strict answer is no for the vast majority of conditions. The one exception would be for hip arthritis, where we know outcomes are actually worse with age. So what sort of doctor does these treatments? Again, my strong treatment is that work with physicians who are focused on musculoskeletal conditions. If your physician is sort of dabbling in this, meaning they're treating somebody's knee and then they're jumping out and giving Botox to somebody, that's not the right person to see. Medicine works by specialization. There's too much out there in medicine. If you stay focused as a professional, you can be properly doing this. And you should be working with physicians who are focused on non-surgical treatments for your condition. Orthopedic surgeons are trained in surgery. That's a very different skill set than if you're trained to do this under image guidance. In fact, there's whole fellowships and training that are based on that. So in the same way, your cardiac surgeon stays focused on doing open heart surgery, and your cardiologist is focused on doing needle-based procedures, it's the same thing here. If your physician does not have that additional training of doing this under high-level image guidance, X-ray and ultrasound, they're not going to really be an expert at this. And then lastly, I'll talk a little bit more about what does it mean to be a proper regenerative medicine expert, because there are big differences between the people who are doing this properly and expertly and the people who are doing this really not with that same level of sophistication. So can these treatments help if I've already had surgery? Again, simple answer, yes. The exception would be if you already had a joint replaced, then in that case, I would not recommend that. There's no area to actually treat at that point. You've got metal or plastic. We can't really treat that. So some common things that we see all the time would be someone that's got knee arthritis, that's had arthroscopy, 5, 10, 20 years ago, or somebody that has a shoulder rotator cuff issue and they had a prior surgery, again, maybe 10 years ago. So my general rules that I recommend people for orthopedic surgeries is, as much as possible, try to keep your own anatomy, avoid surgeries that are strictly cutting out tissue, and always consider regenerative medicine treatment if you've been recommended surgery, because that might be appropriate in your case. Okay, somebody had a very specific question about, does recent FDA guidance include injections must be to a location where cells are harvested? I'm not sure if what you're asking is if you've had a bone marrow aspiration, if you need to have your re-injection back at that same site. That's not what the FDA is saying. The FDA is saying that there's certain tissues where blood and bone marrow are part of the normal healing process. Let's say your knee joint. Injecting your own platelets or bone marrow-derived stem cells is considered appropriate. There's a long history where you have other fields that have actually utilized those same cells in other ways. So as an example, in orthopedics, a previously commonly done surgery was microfracture surgery, where essentially what they would do is in arthritis, they would put holes into the bone, into the cartilage, and have the stem cells and blood drip out. And so that is a great example of where they're already using that for 20, 30 years. In addition, in something like dental surgery or even in spine surgery, there's bone grafts that have been used where they're using, again, your own bone marrow or platelets to help graft some of their surgeries. So when it comes to orthopedic use, there's really a long history where people are using their own blood, platelets, or bone marrow-derived stem cells to augment or treat a surgery or actually treat the condition. And so that is still within FDA guidance, 100%. Really what the FDA is worried about are people taking cells and inappropriately using them from other things. So you may have heard about this clinic in Florida, I believe, where they were taking adipose or fat cells and then injecting those cells into people that had different types of eye conditions and it led to blindness. So that was really far off the mark, in the sense that there was really no data to suggest that that was even safe and appropriate. And they were using that to treat patients and they had bad outcomes. On the other hand, in the field of regenerative medicine for orthopedic use, for treating things like your shoulder, your knee, your back, or other kind of joints or tendons, like there's data and evidence that goes back to the mid-90s. And so that's a very different story than some of the other kind of stuff that was really inappropriately that's been done in the past. Okay, so regenerative medicine concepts, which I'll talk about, include stability, orthobiologics, interventional orthopedics. These are key because if you really want to know, are you getting an appropriate treatment by a physician who knows what they're doing, they need to understand these things. And I think as a patient, it's worthwhile to understand this as well. Number one, it'll help you give a better sense for how to treat yourself. And number two, it'll give you an idea of how to really discern whether your physician is an expert or really an amateur at this. So stability is key when it comes to your joint health. So biotensegrity or tensegrity is this concept in architecture where if you take individual units in a structure that are weak on their own, but if you put them closely aligned to each other and compress them together, you have a much stronger functional unit. So biotensegrity is that same concept when it comes to your own musculoskeletal health. And I'll show an example of that in a moment. But prolotherapy is the idea where you inject your own cells into soft tissue supportive structures to strengthen and stabilize that overall unit. Important because when you treat something like a knee, if you only inject, let's say, your cells into the knee joint, you'll get some benefit. But if you don't treat all the other supportive structures, meaning meniscus, ligaments, tendons, muscles, myofascial tissues, nerves, even bone sometimes, people don't do as well. If you treat all those other supportive tissues, people generally do better because you're now strengthening those other individual structures, which then leads to better stability, strength, and then pain relief and functional improvement. So the key there is to treat all the layers involved in that functional unit, not just that joint or that one area that's been damaged, and to treat even above and below that, that's driving some of the pain as well. What happens is you then get a slowly positive strengthening, progressive strengthening process over time. And so not only do you get a slower gradual improvement over months with these kind of treatments, but you get a longer lasting result as well, which is important. So here's a case study of someone who had a lower back pain. This was a 71-year-old man. He'd had prior lumbar laminectomy. So again, he's had prior surgery in his lower back. And he still had pain. Very common when you see that in lower back patients where they have persistent pain despite prior surgery. So the areas that we treated in his case originally was using his own platelets, platelet-rich plasma, treating his ligaments, facet joints, muscles, and epidural space, treating all those layers of tissue that are involved. His initial improvement was about 30% improvement. We then escalated to using his own bone marrow-derived stem cells, again, treating those same levels of tissue. And now he's at that 75% improvement and he's a few years out from treatment. So that's what our goals are here, to treat all the tissues that are involved, even when someone's had prior surgery or intervention. Next key thing to understand is orthobiologics. Orthobiologics are basically the medical term when you're talking about the tissues and cells that we use for these treatments. So again, uses your normal healing process of platelets and bone marrow-derived stem cells. Use your own cells, not somebody else's cells. That's what's safe and that's what's appropriate and that's what's been studied and that's what's allowed by the FDA. So again, after an injury, your platelets recruit other cells, using inflammation, stimulate your own stem cells, and then start that normal reparative process. Some pictures here. Platelets come in different kind of varieties. Your normal physician, the way that they're doing these treatments, they're using a one-size-fits-all system, meaning they have a centrifuge sitting in the exam room. They take your blood, they'll spin it down, and they kind of give you the same product that they would to anybody else. The problem with that is your condition may require a different treatment than what somebody else has. So what I have shown on the right side is you can create a version of platelet-rich plasma, that's a high concentration of your own platelets, by multiple different methods. And depending on what your issue is, whether you have arthritis, tendonitis, or nerve issues, you have to change how that platelet product is prepared. So if you only do this in a one-size-fits-all method, you're going to get the product that you see on the right, which is a lot of blood in the platelets. And that may not be what's safe or appropriate for you. A better way to do it is to have a lab-based system where you have trained staff to take your blood and your bone marrow and specifically create a product that is very finely tuned for you. If your physician is doing this in a one-size-fits-all system, and unfortunately, a lot of medicine in this country is very much a one-size-fits-all system, you're not going to get an ideal result. An ideal result or a better optimized result is going to be when you have a process that's really prepped specifically for you. How do you know that? Well, if the blood platelets you're getting look like they do on the right side, all red and bloody, you're not getting something that's really prepared properly for you. It should look more like what's on the left side, which is that sort of yellow amber color. That's how you know you're getting a more appropriate treatment. So this is an example of, this is a PRP case study. This is a 45-year-old man, cyclist. He was referred to me by his sports medicine physician. He had an MRI that showed patellar tendonitis causing difficulty with cycling. Picture on the right is an ultrasound image of that, essentially showing a lot of tendon pathology. Under ultrasound guidance, the picture on the right shows a long needle that's going into the tendon under ultrasound guidance. We injected PRP 2 different times into his tendon. He had a great response to treatment and was able to return back to activity. I saw him back a few years later. Now on his other leg, he had hamstring tendonitis. Again, we treated that with platelets and again, back to his active lifestyle. Key things to understand here are to use the right platelet product under image guidance, picking the right condition. And this is someone who's had a great long-term result because of that as well. Stem cells are the other kind of big orthobiologic treatment. It's the mesenchymal stem cells are the main cell that drives tissue repair and recovery after an injury. You should always be using your own cells. If you use somebody else's cells, too many risks with using somebody else's cells. Your body does not react appropriately to that. Use your own cells. Number 2 is understand that bone marrow-derived stem cells are really the only legal living stem cell product that you can use in the US. You may hear about people doing fat stem cells. You may not be hearing as much about it because the FDA is now cracking down on clinics that do that appropriately. The reason why is because there's an enzyme that they use to break down the fat to create stem cells in that kind of product. And the problem with that is the FDA thinks that may not be safe, that enzyme may not be safe to use in humans. So you can still use fat for structural support, but you don't use that enzyme. And it really should not be called a stem cell product. What it is a fat structural product at that point. And it has validity. Your physician really should understand the difference between these different types of stem cell products. If they don't, that's a problem. Amniotic and umbilical cord cell treatments, not hearing as much about that, but there were a lot of chiropractic clinics and physical therapy clinics that were starting to use umbilical cord and amniotic products. FDA starting to clamp down on that because these were being falsely advertised as living stem cell products, and that's not true. The way that these products are prepped, amniotic and umbilical cord cells, they take them after birth, they take the tissue that's remaining, they then send them to a lab, and at that lab, they then pulverize it, gamma radiate it, create a powdered product out of that. They then put that into a glass or plastic vial and then ship that off to the doctor's office, where it can then sit on the shelf for about 2 years before it's then reused. When it's reused, you take some water, they rehydrate it, kind of like you're rehydrating they rehydrate and then they re-inject it at that same time. There's no living cells when you've done that process. And unfortunately, it was being falsely advertised, and so the FDA is starting to clamp down on that. You want to avoid that as well. That's not a stem cell product. IV stem cells you may hear about being used in other parts of the world. No proven benefit for orthopedic conditions. It may help for other things, but not for arthritis and tendonitis. Stem cell treatment outcomes, right? What are the things you should be thinking about? Well, the main outcomes you should be thinking about are it's going to improve your pain and function, frequently even in advanced cases. Why is that? It can improve stability, it can improve inflammation, it can get the cells that are no longer functioning well in your joint to start functioning better, functioning in a more healthy way. And all that will help with not only pain and function, it'll let you do more exercise, which on its own can help with strength and support of the area. Can we improve how your X-ray or MRI images look? If you have significant arthritis, probably not. That's unlikely. If you see a physician or clinic, I've seen chiropractic clinics saying this, where they show an X-ray of how the X-ray looks different. That's not legitimate. That's really not appropriate. For advanced arthritis, we're probably not going to be able to help how the X-ray or MRIs look, but we can still help with pain and functional improvement. If you have a tendon tear that's small, we can still improve with that. Same thing with ligament tears. If you have an arthritic joint, especially knee joints that has a lot of swelling in the bone, we can get that to improve on imaging. And if you have a condition called avascular necrosis where the bone is actually dying off, that can definitely improve as well. Can we treat bone-on-bone arthritis? Simple answer is, it depends on the area, but the simple answer is yes. And the reason why is arthritis is a biologic condition where you can treat all the things that drive that arthritis. Again, and the things that drive arthritis are instability and inflammation. We treat those, and that's why people get better even when they have significant arthritis in the knee or the back. In fact, if your range of motion is still good or close to normal, good outcomes are still very much possible. Caveats here are, number one, if you have advanced hip arthritis, generally we're recommending people go to hip replacement for that because outcomes are harder when it comes to regenerative medicine in that case. And again, understand that if you have advanced arthritis, the expectations are more about improving pain and function as opposed to improving imaging, which is unlikely. Somebody asked a great question. Will PRP help with decreased joint space, for example, worn out shoulder joint? Again, it'll help with pain relief, functional improvement, and your range of motion. Can we get your X-ray to permanently look different? Meaning if you've had shoulder arthritis for a number of years, can we get the X-ray to look different? Unlikely, but we can improve pain and function. I think as a patient, you have to understand that imaging, things like X-ray and MRIs, do not actually correlate with your level of pain. So the classic example is somebody comes into clinic, they've had X-rays of both of their knees, and they'll tell you that their left knee hurts, for example. And you'll look at their X-rays and you'll say, well, your left knee, you've got a little bit of arthritis, your right knee looks much worse. And it turns out the patient doesn't even have pain in the right knee. That's very common. And the reason why is because imaging does not correlate with your actual pain or functional issues. It's the reason why you don't randomly just start checking imaging, X-rays and MRIs on people, because you're not going to do anything about it if somebody does not have pain or functional loss. And so the same thing when it comes to actual expectations of treatment. I'll show you some pictures where we can improve imaging, right? But in someone that's got chronic arthritic issues, we'll improve pain, function, and range of motion, but we're probably not going to improve how the imaging looks. And some people, when they hear that, they ask, well, am I actually getting better? Well, when it comes to treating orthopedic conditions, it's more about treating your actual pain and function in a healthy and low-risk way. It's not as much about improving how the imaging looks, because the imaging does not dictate how your actual quality of life is and pain and function is. Okay, so as I've just said that, here's an example of, okay, so can you improve tendon and ligament tears? This is a knee ACL example. The ACL is a key ligament in the knee. Probably hear about this in a lot of athletes that get injured, but it's injured in people that have chronic arthritis as well. If it's chronically injured, the problem is that it's not only that maybe you can't do that same exercise, but chronic injury to that ligament leads to instability, which then leads to chronic arthritis. What's interesting is that surgically, even if you repair that, it doesn't prevent the progression of arthritis because they still have chronic instability. So regenerative medicine offers the hope of possibly reversing that, preventing that arthritis. So this is an example of a gentleman that has a knee ACL tear. He's a young man, 28-year-old man, ACL tear. He's not a professional athlete. I mean, he's actually a butcher, but he was playing recreational volleyball. I saw him within 2 months after his injury. We did bone marrow aspirate concentrate treatment in his case, stem cell treatment. And at the 3-month mark, he had really significant pain relief and functional improvement where his instability is gone. And he's actually back to doing dynamic activity. And I'll show some images of how his MRI actually improved. So in this case, this structure right here, this kind of long black structure right there, that is his ACL. And this is a needle going into the knee joint. Key, because you cannot do this blindly. You can only really do this with image guidance. So to give you a sense for what his actual MRIs look like, So the MRI on the left is his pre-treatment MRI. This is what his MRI looked like immediately after his injury. This is his ACL right there. Starts down there, ends up here. In between, it's a hazy mess. The radiologist who read this said that that appears to be a full thickness tear of the ACL, but it's not retracted. This is his, on the right side is his post-treatment MRI, where now you have a structure that looks intact, linear, and no longer has that haziness. So he has not only a great result from a functional standpoint and pain standpoint, he has a great result from a imaging result as well. But the key here is we're catching him at an early stage. So this is an example of a 57-year-old man. He's a contractor. There's a lot of overhead activity as part of his work. He had chronic pain in his shoulder, and he actually had a full thickness rotator cuff tear. So the key is we're catching him where, so the image on the left is his ultrasound. This black sort of gap here is his rotator cuff tear. And this is it on the bottom as well. That's a good sized tear of the rotator cuff. And traditionally people would say that can only be treated with surgery. In his case, we use his own bone marrow stem cells and PRP. And this is 3 months later. And now you no longer see that large gap, that black space. Now what you see is filling in of that tissue. So he's had, again, not only a great clinical result, back to work, back to controlled pain, but he's got a great MRI result as well. And he's actually still doing well. I think I treated him about 6 years ago. So the last point I wanted to talk about was interventional orthopedics. So this is the idea of using image guidance to treat your own orthopedic injuries. So I have a lot of colleagues who are perhaps older or maybe younger, just don't have the image guidance experience or training. And they'll tell me that they can inject a lot of these things under just, palpating the tissue over the skin. I would say if you're doing regenerative medicine, you can't do that. So the image on the left is injecting into a rotator cuff tear. So here's the needle, and his tear is essentially less than a millimeter size. You cannot inject that blindly. You have to use ultrasound guidance. Picture on the right, this is again another shoulder. Here's the needle. This is injecting into the joint. We inject a little bit of contrast of prover in the joint, and then we inject it into his labrum. You can't inject all those tissues cleanly and clearly without image guidance. Important because if you're injecting your own cells, if you're just injecting it outside of the joint or the tendon or where it needs to go, you're not going to get the effect that you need. And again, this is an example of where, again, into the knee again. And again, this is into the patellar tendon. That's the needle under ultrasound guidance. And again, on the right, this is into the ACL, injecting under X-ray guidance. Again, cannot do these blindly. You have to do them under image guidance. Last case study here is of a gentleman that has avascular necrosis. He's actually a chef, 41-year-old man. He stands throughout the day. So he has a lot of stress in his ankle. We use the stem cell protocol in his case. The MRI on the left shows that he's got a lot of swelling in the bone. If we don't treat that, that will lead to progressive damage in the ankle. 3 months later, after the stem cell treatment protocol, on the right side, he's got great pain relief, functional improvement, able to stand as he's working. And now that prior swelling and damage in the bone has also resolved as well. So great result on an imaging standpoint, even though I'm saying main focus is on functional improvement and actually pain relief. We do get some imaging results as well. Regenerative medicine treatments are a safe and effective solution for your pain. So other common things that I hear from patients, number one is this too good to be true? So there's evidence that goes back to the mid-1990s from Dr. Philip Hernigue in France. He's an orthopedic surgeon there, treating shoulders and knees since that time. In the Regenerative Network, we have data that goes back to 2005. This is a rapidly developing field for sure, but it's not new. My personal experience goes back to 2008, but I have colleagues that have even longer experience in this. I have patients that'll ask me that their physicians have said this field is too new to really say what to do, that it's low risk, it's not going to hurt them, but they don't know if it's going to work. And they're right that it's low risk, but they're wrong that there's not enough evidence. There's so much solid evidence over the last 10 years that it's very clear that there's right and wrong ways to do this. And if your expectations are grounded in reality and evidence-based medicine, it's appropriate to pursue these treatments. What's unfortunate is that there's colleagues who don't have that same level of experience or knowledge of the field or of the data, and they're guiding patients the wrong way. And again, I'd strongly recommend work with people who are experts at this, not folks who are inexperienced in this or people who are dabbling in this. That's not the right way to practice medicine. How long do results last? So Regenerative has data that goes up to 10 plus years now. Philip Hernigue in France has data that goes up to 20 years. What I still tell people is if you have a chronic condition, expect a repeat treatment at some point down the road, and maybe a few years down the road, and maybe the next year with a booster treatment, but expect that a booster treatment would be helpful after initial treatment at some point down the road. The best ways to maintain results after treatment include improving biomechanics, work with a physical therapist, exercise regularly, take the appropriate supplements, and repeat treatment is typically additive to get you to a higher level. So good question just came through. Can we treat neck issues like osteophytes at C4, C5, C6, C7? Yes. Think about the way you have to understand that is the reason why you have osteophytes or bone spurs is that you have chronic instability in that segment. And the body's only way of treating that instability is to put in more calcium, bone spurs, to help offer some support. So the problem there is not that you have osteophytes or bone spurs. The problem is that you have chronic instability. So absolutely that can be treated. I personally do not treat neck issues. I'm referring that to my colleagues, but absolutely that can be treated with regenerative medicine treatments for sure. Cost. Cost is always a question that comes up, not routinely covered by insurance at this time. There are exceptions to that. So Regenerative has enabled probably about 100 companies around the country right now to add this to their benefits plan. If you're interested in that, and if your company is self-insured, go to regenexcorporate.com and they can guide you through that process. There are some workers' compensation plans that will cover this around the country. And while Medicare does not cover TRICARE, which is the active military insurance, or the insurance for active military professionals, does cover for some specific indications as well. So slowly coverage is coming in, but still traditionally most insurances are not covering it. Costs that you can expect to pay in the United States for these treatments for PRP generally starts at $1,500, and for stem cell treatment starts at $7,500. Keys to determine value, I'd strongly recommend. Number one, are your physicians and the clinic regenerative medicine experts? Are they focused on this? Do they have the right training? Do they know what they're doing? Are you receiving a real stem cell treatment, or are you receiving something that is not real, something like a amniotic or umbilical cord treatment? And lastly, understand that these are in-office procedures. So you're able to avoid hospital and surgery center facility fees, which typically jack up costs by 30% or so. Another great question. So evaluations should be covered, and imaging, things like MRIs, ultrasound, X-rays, absolutely should be covered as part of insurance. It's just the procedure element of things that is not. Good question. All right. Just to give you a sense for kind of how my approach is here at Chicago Arthritis and Regenerative Medicine, focus on non-surgical treatment of your musculoskeletal conditions, starting with evaluating for, do you have inflammation? Do you have instability? Are there asymmetry issues? Do you have any neurologic muscular issues? Start with low risk interventions, exercise, supplements. If you have other big systemic conditions, make sure that's controlled as well. If not working, then escalate to a regenerative medicine treatment. Always make sure you're using the best possible products that are studied and safe and from your own body. Have a plan that is really specifically tailored to your condition and needs. It shouldn't be the same thing that they're offering every patient that's walking through the clinic. It should be nuanced to your issue. I don't think patients fully get that, or the general public gets the difference that when you see your physician, if you're in a kind of factory system versus a system where they're really looking at you individually, that makes a huge difference. If your physician is kind of rushed and just kind of jumping through things and not really thinking it through in a more nuanced way, that's not how you want to get treated. I wouldn't recommend that to my family or relatives or to any of my patients either. And then lastly, your physician should take the time to do these kind of treatments under the highest level of imaging guidance. If they're doing this blindly, meaning they're not using X-ray ultrasound guidance, you're not getting the right kind of treatment, and you deserve better than that. If interested in getting evaluated, or if you have other questions, probably easiest ways to get to us are really going through the website, chicagoarthritis.com. I don't think I have the email listed here, but it's admin@chicagoarthritis.com. But if you go through the website, you can reach us there anytime. If you have questions, if you have, or if you'd like to be evaluated, please go through the website for that. Before I shut down here, please let me know if you have any other questions. I appreciate everyone's time during the middle of the day. And okay, so here's a good question. Somebody asking if they're an overseas patient, how much time should they expect to take? Yeah, great question. So if it's platelet-rich plasma, that's just one day. If it's the Regenerative stem cell protocol, that's 3 steps to that. You can do that over a week, basically. So you'd expect to be kind of block out about a week or so to really properly do that. And I'd recommend taking your time to do that because number one, while the recovery from this is obviously much faster than surgery, you're still going to have more inflammation for the first couple of days after treatment. So for the stem cell protocol, it's essentially a 1 week kind of process. Somebody else asking, any peer-reviewed papers demonstrating efficacy of Regenerative? Yes, absolutely. I believe we have those listed on chicagoarthritis.com. There should be a section on literature for that. On the Regenerative main website, regenerative.com, there certainly is as well. If you're having difficulty finding that, just ping us, email us, and we can send you a link for that. Okay, great question. Post-procedure recovery. Yeah, a lot of it depends on what's your baseline and what's the procedure done, right? So as a kind of general rule, after treatment, you want to expect inflammation for at least the first 3 days or so after treatment. If you're more prone to inflammation, let's say you have an autoimmune history, that inflammation can last for about a week or so. Stiffness can last for a week or 2 after that as well. You're not inhibiting or hurting the effects of treatment if you get back to activity sooner, but you'll just be more uncomfortable. So what I normally tell people is expect to be low impact, meaning doing your regular activities during the day, but really limiting any high impact activities for that first week for sure. And then part of it depends on what sports you're trying to get back to. So first and foremost, if you're trying to get back to running or something high impact like that, and you haven't done that in years, right? I mean, that is a slow progressive getting back to that. If that's an activity you've been doing until, let's say, a recent injury, or you've been doing until recent treatment, what I would recommend is for the first week after treatment, definitely want to shut it down and be low impact. You can do low impact exercises to kind of maintain blood flow, flexibility, and that sort of thing. And as you get back into activity, whether at the 1 week mark or the 2 week mark, you want to start at a low level, let's say 30% of your normal activity level, and then every week as tolerated, increase by 10%. So we frequently end up referring patients to physical therapy, and there's a whole detailed kind of process to how we recommend they do it. But what I just described, starting at 30% and increasing by 10% every week, is in essence what it is. So the goal, if you have, for patients that I have that are, let's say, I have a patient who's coming in kind of soon, who is a triathlete, and he has a race coming up in a month, that's going to affect the kind of treatment we're going to do for him. So I know that there are treatments that we can do where he can get back to training within a week. That'll get him through his current race. And that post-race will now probably have to reevaluate and decide if he needs something that's a little bit more expansive in terms of treatment to give him a better longer-term result. So it's very individual depending on what the issue is, but what I've described, that first week, definitely low impact, and then maybe another week of kind of still low impact or a little bit more, and then progressively increasing is what I would expect. I hope that makes sense. Yeah, those are some good questions. Any other questions before I wrap it up here? Okay, great. Well, thank you very much, everyone, for your time. And again, email us if you have any other questions. And until we connect again, have a good day and live well. Thank you. Bye-bye.